Hello, everyone. Today, Rehab Podcast Weekly presents the topic meniscal tear treatment and rehabilitation.
Okay, so knee injuries, gosh, they're almost a rite of passage, right?
Yeah, definitely. Especially if you're active.
And right near the top of that list, you always hear about meniscal tears. I mean, the stat is something like 61 new cases per 100,000 people every year.
It's incredibly common. It's a really frequent reason folks like you end up coming to see us in physical therapy.
Absolutely. And, for someone interested in how we as PTs actually think about these injuries, this deep dive should be really useful.
Exactly. We've sort of pooled our experience, looked at the standard protocols, the guidelines, and checked out the latest research.
Right, just to give you a really clear picture of the current thinking.
Yeah. Our mission today is basically to cut through some of the complexity and give you the key insights into managing meniscal tears from a PT perspective.
Okay, so what are we covering?
Well, we'll definitely talk about the big shift happening, this whole save the meniscus idea.
Ah, okay.
And then, the basic anatomy that really dictates healing potential, how we classify the different types of tears.
Which then drives the treatment, right?
Totally. And we'll look at both angles, the conservative, non-surgical approach, and then the rehab side after surgery. Plus, we'll touch on some newer therapies that are emerging.
And we've got some solid sources for this, a PubMed review on repair techniques, that MGH rehab protocol.
Yep, the Brigham and Women's Standard for Conservative Care, a review on stem cells, which is interesting.
And even some insights from PHCN online. So a good mix.
Yeah, should be a good overview.
All right, let's dive in then. This save the meniscus era you mentioned, that feels like a pretty fundamental change.
It really is. I mean, it wasn't that long ago that a tear often just meant surgery to, remove the damaged part, a meniscectomy.
Either partial or even the whole thing sometimes. What really drove that change? Why save it now?
It really boils down to a much deeper understanding of what the meniscus actually does.
It's not just a passive spacer in there.
Not at all. It's incredibly important for the knee's mechanics. We now understand that taking it out can really mess with how the joint works long term. It increases the risk of arthritis down the road.
Okay, so it's doing more than just cushioning.
Oh, much more. It's vital for distributing the load, the weight, across the knee joint evenly. It provides stability, especially when you twist or turn.
Like rotational stability.
Exactly.
Yeah.
And it even helps with lubrication. Think about this. If you remove the meniscus, the knee loses about 20% of its shock absorption capacity.
Wow, 20%. That's significant.
It is, because you lose those viscoelastic properties.
Right.
So yeah, preservation, saving it whenever possible, that's really the goal now.
Makes complete sense. So if we want to save it, we need to understand it. Let's talk structure and healing. What's it made of?
Okay, so structurally, it's mostly water, actually. And then the main building block is type I collagen, which is really strong and resilient.
Right.
But the absolute key factor for healing is blood supply. That's the decider, really. We talked about these zones. There's the outer third, the red zone, good blood flow there.
So good healing potential.
Exactly.
Yeah.
Then the middle third is the red-white zone,
Yeah.
kind of transitional, some blood supply, but less.
Okay.
And then the inner third, the white zone, is essentially avascular. Very little or no blood supply.
Ah, so a tear way out in that red zone has a much better chance of healing, whether on its own or if a surgeon repairs it.
Precisely. Tears in that outer vascular part, they just have a significantly better prognosis. And there's a slight difference between the two menisci P rosetten. The medial one on the inside has maybe 20–30% vascularity peripherally.
And the lateral.
A bit less, maybe
Yeah.
10–25%. So yeah, where the tear is located dramatically influences treatment choices.
Got it. And I heard they have nerve endings too. Is that why they hurt?
They do. They have pain receptors, nociceptors, so yes, they can definitely be a source of pain when injured.
Huh.
But interestingly, they also have mechanoreceptors. These contribute to proprioception.
Your sense of joint position.
Exactly. Where your knee is in space. That's why sometimes with a meniscal tear, your knee might feel a bit unstable or like you don't quite trust it. That sense can be thrown off.
Okay, so location, blood supply, tear pattern, these are all critical pieces of the puzzle for us as PTs. How do we typically classify these tears? What are the main types we see?
Yeah, classification is key because it really guides what we do. We look closely at the pattern of the tear itself. That PubMed review had some useful diagrams, actually.
You figure one, I remember those. Can you walk us through the common ones?
Sure. So you have longitudinal tears, or vertical tears. They run along the length of the meniscus, parallel to the collagen fibers.
Okay.
These are often on the medial side, the inside. And crucially, if they're in that outer vascular zone, they might be repairable.
Right. What else?
Then there are radial tears. These go from the inner edge outwards towards the periphery, often seen in the back part, the posterior horn.
Okay.
Horizontal tears run parallel to the top of the tibia, basically splitting the meniscus into an upper and lower layer.
Like a flap.
Kind of, yeah. And then you get the ones that sound dramatic, the bucket handle tears.
Yeah, what are those exactly?
That's essentially a big longitudinal tear where a large segment flips over into the joint, like a bucket handle.
Ah, and that causes locking?
Often, yes. That mechanical block where you physically can't straighten the knee, that's a classic sign.
Okay.
And lastly, there are degenerative or complex tears. These usually involve multiple patterns, maybe some fraying. They're often linked with osteoarthritis, more common as people get older, and generally aren't suitable for repair.
So, quite a range of possibilities. And you mentioned the Cooper classification briefly.
Yeah, that's just another system, a bit more detailed, divides the meniscus into different zones radially and circumferentially. Surgeons might use it for very precise descriptions, but the patterns are usually what we focus on more in rehab.
Got it. Okay, so let's say someone comes in, they have a diagnosed tear. When would you lean towards conservative management, like just physical therapy without surgery?
Conservative care is often the first line, definitely, especially for those degenerative tears in, say, older adults without locking symptoms,
Okay.
or maybe smaller tears located in that inner white zone where surgery might not help much anyway, or even some stable longitudinal tears that aren't causing major issues.
So, what are the goals then in conservative PT?
The main goals are pretty universal. Calm down the pain and swelling, restore the knee's range of motion, get the muscles around the knees strong again, particularly the quads, and improve that neuromuscular control we talked about.
Makes sense. What does that look like in the early stages? What kind of things are you doing?
Initially, it's a lot about calming things down. So relative rest, meaning avoiding activities that really aggravate it.
Like deep squatting, kneeling, twisting.
Exactly.
Oh.
Ice, maybe compression, keeping it elevated helps with swelling.
Hmm.
And crucially, starting gentle isometric exercises for the quadriceps almost immediately.
Why the quads so early?
Because they tend to shut down really quickly after any injury, and maintaining that muscle activation is vital for stability and function later on. So gentle quad sets are key.
Are there things you specifically tell people not to do early on?
Yeah, we usually advise against activities that involve deep knee bending under load. So deep squats are out initially, maybe rowing machines depending on the setup.
Okay.
We also often limit weight bearing at first, maybe using crutches for a bit, and then gradually progress how much weight they put through the leg as symptoms allow. Things like functional hop tests, those are for much later stages, usually for athletes getting back to sport. Way too early initially.
Right. And how do you know if this conservative approach is actually working? What are you looking for?
We want to see symptoms improving steadily. So less pain, less swelling. They should be able to bear more weight comfortably,
Yeah.
and their range of motion should be gradually increasing, maybe with just a little bit of pain right at the very end of bending the knee fully. That's usually a good sign.
Okay. But sometimes surgery is the best option, like for that bucket handle tear, maybe. What does PT look like after a meniscal repair? That MGH protocol sounded quite detailed.
It is. It provides a really good structured framework, but you always have to remember these are guidelines. The actual rehab needs to be tailored.
Tailored to the specific tear, the surgery type.
Exactly. And how the individual is progressing. But yeah, the phased approach like MGH uses is very common.
So let's walk through it. Phase I, right after surgery, first few weeks, 0 to 3 weeks. What's the focus?
Phase I is all about protection. Protecting that surgical repair is paramount.
Number one priority.
Absolutely. Secondary goals. Reduce pain and swelling, get the kneecap moving freely, patellar mobility, and regain full extension. Getting the knee straight is critical.
And flexion, bending.
That's limited, usually less than 90 degrees initially, sometimes even less depending on the surgeon's preference, and we need to start getting that quad firing again.
So what interventions are used?
The usual suspects for swelling and pain. Ice, compression, elevation. Maybe some gentle massage. Ankle pumps for circulation. Gentle patellar mobs. For range of motion, it's usually passive or assisted flexion and extension, avoiding active hamstring contraction for flexion early on.
Okay.
Low load, long duration stretches for extension. Quad sets, maybe using NMES, that electrical stimulation, to help wake the quad up. Some gentle hip strengthening, like abduction isometrics. Multi-angle isometrics for the quad are okay, but no straight leg raises if there's an extension lag, if the knee droops when they try to lift it.
Got it. And what gets them to phase 2?
We need to see 0 degrees of extension fully straight, at least 90 degrees of flexion, a good, solid quad contraction where you can see the kneecap moving, and importantly, being able to do a straight leg raise without that lag.
Okay, that's a clear set of goals. Phase 2 then, roughly 3 to 6 weeks post-op. What changes?
Still protecting the repair. That's ongoing. Continue managing any pain or swelling. Maintain that full extension. Flexion might start to increase a bit past 90, but usually we're still cautious, following the surgeon's guidelines. Weight bearing might start to progress too.
And exercises.
They'd continue a lot from phase 1, but add things like gentle stationary biking, often starting with high seat, low resistance, just for motion. Upper body ergometer for cardio. Calf raises. More focus on lumbo-pelvic, strengthening things like clamshells, planks, bridges. And starting some basic balance work, maybe double M on an unstable surface. And joint position retraining exercises.
Progression criteria for moving on from phase 2.
Generally looking for minimal swelling. There are tests like the modified stroke test we can use. Getting flexion up to maybe 120 degrees. And extension still matching the other side, perfectly straight.
Right. Moving along then, phase 3, maybe 6 to 9 weeks. What's the emphasis here?
Protection is still there, but now we're really focusing on normalizing their walking pattern, their gait, and getting flexion closer to the other side, maybe within 10 degrees. We start to progress, strengthening more, but always emphasizing proper movement patterns and watching carefully for any negative reaction like pain or swelling after exercise.
What new exercises come in?
We keep building. Might add gentle, active hamstring stretches now, other stretches as needed. Maybe some gentle joint mobilizations if motion is still stuck. More biking, maybe pool exercises if available, the buoyancy helps. Starting partial squats, maybe 0 to 60 degrees range initially. Ball squats against a wall. Hamstring curls. More advanced core work. And introducing some gym machines carefully, leg press, hip machines, calf raises.
And to get out of phase 3?
Key things are no pain or swelling after their exercises, a normal gait pattern, range of motion pretty much equal to the other side, and good symmetrical joint position sense usually tested, looking for less than 5 degrees of error compared to the good side.
Things seem to ramp up in phase 4 around 9 to 12 weeks.
Yeah, phase 4 is kind of a transition towards higher level stuff. We need to maintain that full ROM, continue progressing strength safely, but really drill down on proper movement patterns, especially single leg control and hip stability.
What about cardio and strengthening?
We can add things like the elliptical or stair climber. Strengthening focuses on more controlled, functional exercises, squats to a chair, lateral lunges, starting single leg progressions like step-ups or single leg squats, Romanian deadlifts for the posterior chain.
Progression criteria here sound more demanding.
They are. We need to see no signs of instability. They should be able to perform maybe 10 single leg squats with good form. We start using patient-reported outcome scores more, like the KOS, looking for good scores related to sports rec activities, and strength testing aiming for at least 80% strength in quads, hamstrings, and glutes compared to the uninjured side.
Okay, and then we finally hit the return to sport phases. Phase V starting maybe 3 to 5 months out.
Right. Phase V is that early return to sport phase. The big goal is safely progressing strength and starting sport-specific training, always watching movement quality.
What does that involve?
We continue building on everything before. We typically introduce a structured interval running program, start some basic plyometrics, jumping and landing drills and agility work. Sometimes this is done with a functional brace initially.
And getting clearance for unrestricted sport.
That requires several things. Clearance from the surgeon, obviously. Completing that running program without sinews. Hitting high marks on functional tests, strength indices usually need to be 90% or better now. Good hamstring to quad strength ratio. Hop testing symmetry should also be 90% or better, and high scores on those outcome measures like KOS Sports and IKDC indicating they feel ready and confident.
Wow, quite the checklist. And finally, phase 6, 6 months plus.
Yeah, unrestricted return to sport. This is about continuing to fine-tune strength and proprioception and ensuring they can perform their sport-specific skills symmetrically and confidently.
So, more advanced drills.
Exactly. More complex, multi-directional plyometrics and agility. Hard cutting, pivoting things that really stress the knee in sport-specific ways. It involves a gradual return to full practice participation and then eventually gameplay.
And discharge from PT.
Usually when they consistently meet those high-level criteria, strength and hop tests at 90% or better, and demonstrating symmetrical, pain-free performance in their specific sports demands.
That is a really comprehensive breakdown of the post-op journey. Thanks for that. Let's switch gears slightly. You mentioned emerging therapies, specifically stem cells. That review sounded intriguing, but maybe still early days.
Yeah, it's definitely an area generating a lot of excitement. The core idea is harnessing the potential of stem cells to actually help the meniscus heal itself better,
Okay.
especially in those tricky white zones with poor blood supply.
Right, trying to regenerate tissue rather than just repair or remove. Where do
Yeah.
these cells come from?
The main focus has been on mesenchymal stem cells, MSCs. You can get them from a few places. In the body, bone marrow is common, adipose tissue, or fat. And also the synovium, the tissue that lines the joint capsule. Some early work actually suggests these synovial MSCs might be particularly good at turning into cartilage-like cells, which is what you want for meniscus repair.
Interesting. What did the animal studies show? Did injecting stem cells help?
Well, quite a few preclinical studies, in pigs, rabbits, dogs, horses, have shown some promising results. Injecting MSCs into tears seemed to lead to improved healing, better collagen formation, and stronger repair tissue compared to controls.
Any caveats?
Some studies suggested that maybe treating tears earlier, when they're more acute, might work better than treating older chronic tears. But overall, the trend in animal models was positive.
And are people trying other things besides just injecting the cells?
Oh yeah, definitely. That's where tissue engineering comes in. Researchers are experimenting with combining MSCs with biocompatible scaffolds, sort of like a framework for the cells to grow on, and adding growth factors to stimulate the process even more.
Trying to build a better meniscus patch, essentially.
Kind of, yeah. Trying to generate repair tissue that's closer in quality to the original meniscus. There are even approaches trying scaffold-free techniques, just using aggregates of the cells themselves. Lots of different strategies being explored in animal models.
Okay, so lots happening in the lab and in animals. What about actual clinical studies in humans?
That's where things are still developing. There have been some early clinical studies, case reports, small series, looking at injecting stem cells for meniscal tears.
And the results.
Generally, they've reported positive trends. Patients often report reduced pain. And some studies have even shown evidence on MRI scans of an increase in meniscal volume or improved appearance after treatment.
What?
But it's really important to emphasize these are mostly smaller, often uncontrolled studies. So while the signals are encouraging, we don't have large-scale, high-quality, randomized controlled trials yet to definitively prove effectiveness and long-term safety.
So promising, exciting, but still needs more rigorous research before it becomes standard practice.
Exactly. It's one to watch, for sure, but not quite prime time yet.
Okay. So bringing everything together then, conservative care, surgical repair, post-op rehab, potential future therapies, how does a PT help someone navigate these choices? When is surgery really the way to go versus sticking with conservative?
Like we said, conservative is often the starting point, especially for those degenerative tears without mechanical symptoms or maybe small tears in the avascular zone. It works well for many people.
Right.
Surgery becomes a stronger consideration for acute traumatic tears, especially in younger, active individuals, or if there's definite mechanical locking, like with a bucket handle tear that just won't reduce.
And if conservative care just isn't cutting it after a decent trial.
Exactly. If someone's done several weeks or months of good rehab and they're still significantly limited by pain or instability, then revisiting the surgical option makes sense.
And that decision still heavily relies on the tear type and location, right? That vascularity question.
Absolutely critical. A tear in the peripheral red zone is a much better candidate for a successful repair surgery than one deep in the white zone.
Yeah.
And it's worth noting, even with knee osteoarthritis, where general guidelines often caution against arthroscopy, the specific role of trimming a torn meniscus in that context is still debated. It's not always clear-cut.
So it really emphasizes the need for a thorough evaluation, understanding the individual patient, the exact nature of their tear, and their symptoms and goals.
Precisely. And the physical therapist is involved every step of the way, guiding conservative care, preparing someone for surgery if needed, and then managing that whole complex rehabilitation process afterwards.
Well, this has been incredibly insightful, a really great deep dive into how we, from a physical therapy viewpoint, approach these really common meniscal injuries.
Yeah, hopefully it gives you a good sense of the current landscape.
Totally. We've touched on that big philosophical shift towards saving the meniscus, the crucial role of anatomy and blood supply, how we classify tears, the details of both conservative and post-surgical rehab pathways.
And even a glimpse into potential future biological treatments like stem cells.
The main takeaways seem to be that our understanding is always evolving. Getting the diagnosis and classification right is key. There's a whole spectrum of treatment options.
And physical therapy is fundamental throughout the entire process, regardless of the path taken.
And that save the meniscus philosophy really underlines the long-term value we now place on preserving that structure for knee health.
It really does. Thinking long-term joint health is key.
So maybe a final thought for you to ponder. With surgical techniques getting better, rehab protocols becoming more sophisticated and personalized, and these biological treatments on the horizon, what do you think the standard of care for meniscal tears might look like in, say, the next 10 years?
That's a great question.
Will we see an even stronger push for conservative care first? More biologically augmented repairs? Even more individualized rehab based on specific tear types and patient factors?
It's fascinating to think about. Definitely suggests a future where treatment becomes even more targeted and hopefully even more effective at preserving long-term knee function. Something to keep an eye on.
Edited by Min.Rehab. Thank you all for listening, and see you in the next podcast.